Good morning, everyone. Today, my presentation topic is method of gaining space. See, in orthodontics, space gaining is very important factor when we are treating with the crowded case, procline teeth, or different type of the malocclusion. So, if we start with the contents, so why space is required? For the resolution of majority of the malocclusion, generally we require space in the orthodontics. The first one is what are the indication when we require the space for the orthodontic patient. The first one is alignment of the crowded teeth. When patient comes to us, they have usually the chief complaint of either procline or crowded teeth. So for that we require the space. So alignment of the crowded teeth. Second one is the retraction of the procline teeth. Third one is the correction of molar relationship. Fourth one, if we want to derotate the anterior teeth, so we require the space. Then leveling of curve of spee. If we want to level the curve of spee, so we require some intrusive movement or some extrusive movement. So both of the movements require the space. Even correction of the anterior posterior crossbite, correction of narrow dental arch if we want to do expansion and we want to do intrusion. That is a true intrusion. For all this type of the cases, we require the space. So management of the space in orthodontics is very important. If we want to treat the case nicely and we want to give the good result. So let's start with the discussion with the first topic, which are the methods of the gaining space. So space gaining methods basically divided into three parts. Either non-extraction, second is the extraction, and third one is the surgical. Which method to be selected, it depends on various diagnostics of the orthodontist. First one is the non-extraction method, in which it comes with the proximal stripping, arch expansion, molar distalization, uprighting of the tilted teeth, derotation of the posterior teeth, and proclination of the anterior teeth. See, these are the 5 techniques in which we don't require any type of the extraction. Second one is the extraction. So space can be gained by the extraction. So first one is the balancing extraction. Second one is the compensating extraction. Third one is the phase extraction. Fourth one is the enforced extraction. Then Wilkinson extraction and therapeutic extraction. These are the different types of method of either serial extraction and the therapeutic extraction of the first premolar. And the third is surgical. It is basically for orthodontic surgery and extraction osteogenesis. So which are the non-extraction method which we generally encounter while treating the orthodontic patient? So first one is the proximal stripping, which involves a selective reduction of the mesiodistal width of the certain teeth. But it depends on different types of the teeth anatomy. Even also it depends on different type of the cases. So this is also the another name of this technique is proximal slicing, reproximation or slenderization. So what are the indication for proximal stripping? Which normally when the space requirement is minimal, which is 2.5 to 3 millimeter, or the Bolton tooth material excess is less than 2.5 millimeter. In this type of patient, we normally don't prefer the extraction. So basically, we plan stripping in mandibular anterior segment. So what are the contraindication of proximal stripping? The patients who are susceptible for caries. We cannot do stripping in this type of patient because we are giving chance to development of the more caries. Even it is avoided in young individuals as their pulp counts are very high. So development of sensitivity is very high in the young individuals. So what is the exact procedure we need to follow while doing the stripping? First one is assessing the space required. We has to first assess the space requirements at how much space is required for doing the stripping. It must be less than 2.5 mm. Second one is selecting the teeth and amount of enamel to be stripped. There is one measurement that is a pet and pet ratio, which normally we prefer for the mandibular anterior teeth. but not more than 50% of enamel thickness to be stripped. That is the basic tool before starting or doing the stripping. Then enamel stripping is generally performed using the following method. The first one is the metal abrasive strip. We generally break the contact between the teeth or we start with the abrasive strip. This is the efficient and the safe way. In this type of technique, we don't have any fear to get more stripping between two teeth because it is a minimal stripping technique. Second one is the aerator stripping method. It is basically the safe side is carborundum disc, which is normally we preferred because it also strip minimally and the efficient stripping. Second is the perforated diamond disc. This is also the efficient way, but it is a little bit faster. So we need to be careful while doing with the diamond disc or tungsten or diamond burr or thin Fisher burr. In this type of technique, when we are using aerator, we need to be careful that we don't strip more as we require. So you can see in the figure A, we generally prefer stripping with the strips. And in second and third, you can see first B is the carbide strip and the C is that is the diamond disc. So after reproximation, there will be development of sensitivity because we are exposing the dentin. So in this type of patient, there is a low concentration of calcium fluoride solution is required to reduce the sensitivity in this patient. So what are the advantage of proximal stripping? We can avoid extraction in borderline cases. So we can, when there is a minimal space requirement, in this type of patient, we can avoid extraction. To achieve better interdigitation, that is basically for overjet and overbite. Even when we just want to correct, there is a minimal discrepancy in overjet and overbite, we can stripping. Third one is to broaden the context to add the stability of the result. And the fourth one, localized malalignment can be corrected without involving too much teeth. So these are the all advantage of proximal stripping which we can get. Now, what are the disadvantages? The main disadvantage of proximal stripping is if we don't proper plan and if we don't follow the protocols of the stripping, there is development of sensitivity and development of caries. These are the main two complications which we usually face with the proximal stripping. So it is third is very difficult to reproduce the exact morphology with the for this reason we need lot of practice on the models and the patients required. Even the shape created what we create by stripping it may not be aesthetic because we cannot judge before. And the last is if we change the natural contact point and if we not correct with the orthodontic treatment. So there is the chances of development of food lodgement. There is a main patient's complaint. And if there is a patient complaint of food lodgement, then we need to do again treatment and we need to do again caring. So these are the all the problems normally we get with the proximal stripping. Now the second technique for gaining space is arch expansion. There are basically two type of expansion, rapid maxillary expansion and slow expansion. The rapid expansion, it may be either removable or the fixed. So which are the rapid maxillary expansion device? In orthodontics, in the short form, it is called RME device. It is first developed in 1860 by Emerson C. Engine. There are kind of dentofacial orthopedics which open the mid-palatal suture if we give in the proper age. The 15 to 19-year age is more preferable time. Even we can give with the 11 to 15-year of the patient to open the suture. Even posterior teeth are used to transmit the forces of expansion. And first, what after expansion, first we will see the midline diastema. Then we can justify our result of the expansion. Sometimes open bite may be possible, which can be further corrected with the orthodontic treatment. So what are the indication for rapid maxillary expansion? See, in orthodontics, how we can get space, it is different in every patient. For that, orthodontists need to understand every diagnostic protocol and treatment planning because in all the patient, we cannot do the stripping, RME or extraction, everything together. We have to select the case and we have to plan proper treatment. So what are the indication of RME? First one is growing individuals. with severely constricted maxillary arches. Even there is airway impairment, mouth breathing habit. Second one is the posterior frostbite, which is relatively maxillary deficiency. Cleft palate patient. Along with the face mask therapy, we can use RME. Class 3 cases with minor maxillary deficiency, we required RME to loosen up the suture of the maxillary bone. And even also we can use as a part of the interceptive orthodontics. In this figure, we can see there is a removable RME appliance, which usually jets through, which we add in the removable plate, which is efficient also, but we prefer this technique in the mixed dentition period, not in the permanent dentition, because in permanent dentition, we require RME. The You can see there is a different type of the RME appliances. The first one is the tooth bone appliance, that is the Hyrax appliance, in which we can get the support of the molar. You can see molar and premolar, and we solder the one bar and the screw together, and that is the Hyrax appliance. This is the figure of Isachan appliance which was previously used, in which there is one compressed coil which is placed between the posterior teeth, and it is soldered with the posterior bars, and we can give the force in the expansion force in the posterior teeth. These are the tooth and tissue bone appliance. Tooth and tissue bones means we are getting support from the tooth and the tissues both. So you can see there is bands prepared on the premolar and molar. Even there is a plate in the palate, and we have given the screw. So it's expanding that. Second one is the Hess RME appliance. Even in this also you can see there is a band in the posterior and acrylic plate over the palate. So these are the tooth and tissue bone appliance. Now there is a slow expansion. Where to give slow expansion when we want to correct the unilateral crossbite? There is a V-shaped arch. There is a minimal crowding in the upper arch. Even we prepare the case for the bone grafting in the cleft cases and to elimination of the displacement. So as a retention purpose after RME. So these are the normal indication of the slow expansion device. In slow expansion device, you can see in the figure, the first one is a screw appliance in the upper and lower. In upper and lower, we have given the screw in the maxillary arch. And it is in first figure, you can see there is a three plate screw in which they procline the anterior teeth, even they expand the posterior teeth. In mandibular, it's a Schwarz appliance which expand the mandible, and we can get the space in the mandibular teeth. Second one is a coffin spring. It is a palatal spring which we can prepare, and we can give the arms, and it can expand the posterior teeth. Then quad helix. The quad helix is the four loop helix. There are four helix in that, and there are arm extended over the premolars and the canine. And we have to activate. There is an anterior and the posterior helix, and it gives the expansion force. This is a very nice appliance. Even this appliance we can use with the fixed orthodontic treatment. And the last one is the night-eye expander. You can see in the figure the night-eye wire is compressed in such a way it gives the force posteriorly and it can expand the teeth. And this is a Schwarz appliance which we have already discussed. Now comes with the distalization of the molar. The main purpose of distalization is to push the maxillary and mandibular terminal molars posteriorly. If we see the class 2 division 1 malocclusion, normally we see the molar relation is class 2. But if we see the face, there is not much proclination. So we want to retract the maxilla without doing extraction. In those type of cases, the distalization of molar is required. This is difficult one, but we can correct that if we select the proper mechanics and proper edge group. So there are two types of distalization appliances, basically extraoral distalization appliances and intraoral distalization appliances. In extraoral distalization appliances, the most frequently used extraoral appliances are headgear. Headgear are very commonly used appliance which we use for the distalization movement of the molar. The normal wearing time of there is 12 to 14 minutes. This is the headgear. You can see the figure. The first one is a parietal headgear. Second one is a cervical headgear. And third one is the occipital headgear. And what are the intraoral methods of distalizing molar are the screws, open coil spring, and wire spring with the helicals. These are the different names of the distalization appliance. Now the last is uprighting of the tilted posterior teeth. In this different type of the springs and the micro implant, we can upright the posterior teeth and we can get. So for this, we can get the space and we can give the better prosthesis into the patients. So these are the springs. Now we can also get with the derotation of the posterior teeth. If we derotate the posterior teeth, we can get the space, and which is also very important to treat the patient non-extension. Even proclination of the anterior teeth. Sometimes when we see the patient with the retrocline teeth, if we procline the teeth, then the arch perimeter will be increased. So we can get the space. So better stability also can be achieved. So these are the all techniques of getting the space. We start with the expansion, proximal stripping, derotation of the posterior teeth, then proclination of the anterior teeth, different expansion method, and uprighting of the posterior teeth. With all these techniques, we can get the space and we can utilize with the patient and we can treat the patient with the non-extension. Thank you.